Hello, my name is Robert Henry. I am a student enrolled at Colorado Christian University and currently taking Introduction to Healthcare Informatics taught by Dr. M. What follows is a short presentation on the use of healthcare informatics to decrease medical errors. The objectives of this presentation are to address the overwhelming number of preventable deaths due to medical errors, show how analysis of data from EHRs can decrease the number of medical errors, illustrate that health information systems can be utilized to report and track the number of medical errors and the impact to the patient. Recommend that legislation is needed to effect change, a law requiring that medical errors be reported to and tracked by the CDC. The current state of medical errors. Michael Daniels stated in his 2016 report that analyzing medical death rate data over an 8-year period, Johns Hopkins patient safety experts have calculated that more than 250,000 deaths per year are due to medical error in the U.S. Their figure, published May 3rd in the BMJ, surpasses U.S. Centers Disease Control and Prevention's third leading cause of death, respiratory disease, which kills close to 150,000 people per year. The Johns Hopkins team says that the CDC's way of collecting national health statistics fails to classify medical errors separately on the death certificate. The researchers are advocating for updated criteria for classifying deaths on death certificates. Daniel points that the CDC should be reporting the number of deaths due to medical errors, similar to the way it is reported associated to heart disease, cancer, and respiratory diseases. Dorian, Hines, and Thompson argue that the statistics are inaccurate. Many experts in the field of health safety were surprised by the high number of deaths attributed to medical error in the BMJ publication. He thinks a more accurate number is in the neighborhood of 2% of deaths based on studies which estimate deaths due to medical error make up 5.2%, 3.6%, and less than 1% in hospital deaths. This would correspond to the 15,000 to 35,000 deaths per year in the U.S., an order of magnitude lower than the BMJ estimate. They continue to state Forrester speculated why the BMJ study may have been published despite the flawed methodology. Some people in the patient safety world feel like they have to generate these statistics to help wake up people to the scale of the problem, he says. The argument that as long as people recognize the flaws, the attention it generates is a good thing. Godley seems to agree. Methodology is a little bit misguided, and it's hard to agree on the right methodology, but that shouldn't stop us from trying, she says. It's a good thing that there is awareness and that it is raised. The takeaway from this report is that there is a debate about the scale of the problem. However, it is clearly a problem, and unless it is tracked and reported, we will never begin to understand its scale. The Betsy Lyman Center for Patient Safety conducted an assessment of the healthcare systems in the state of Massachusetts and found that in 1 year that 61,982 medical errors have been recorded. The state suffered $617 million in excess costs attributed to errors. Many people suffer from the financial setbacks due to medical errors, a 33% decrease in income, a 50% increased medical expense, and 33% increased household expenses. 12% of patients felt strong impacts that lasted greater than a year, 19% felt strong impacts for a year or less, and 12%, or 7,437 of the patients, died from the medical error. For the population of 6.893 million citizens in Massachusetts, 61,982 only represent 9%, with a 0.1% chance of death. But if we apply the same statistics to all of America, the 328.2 million, then we are looking at a medical error number of 29.538 million, and death from medical errors that would total 328.2 thousand annually. Keep in mind, these are only the errors that were reported. Malthus and North found in their study into the analysis of apologies in the EHR and what that indicated about healthcare quality, processes, and safety. They concluded 73% of the event types identified by apology review were not present in the incident report logs. Incident report logs predominantly identified events which occurred while the patient was physically present in the clinic. Examples included mislabeled specimen containers, falls in the clinic, or improperly administered medications. In contrast, review of apologies predominantly identified issues arising outside of any face-to-face encounter. Examples included delayed responses to patient inquiries, inadequate integration of the outside medical records, and dissatisfaction with care provided in specialty clinics. Notably, the free text apology search identified numerous events where patients brought care process concerns to light, whereas this was uncommon in incident reports. Similar rates of events leading to harm that using our aforementioned definitions were found in both modes of safety surveillance. Kent illustrates that one basic requirement for effective implementation is the use of standard clinical vocabulary and definitions for reporting of diagnostic results. The ECRI team wrote, this recommendation requires rulemaking by government authorities, development of standards by provider and professional organizations, implementation of these standards into commercial solutions, and enforcing the use of these standards by organizational leadership and health IT developers. To further improve communication among stakeholders, the group advised health IT developers to modify existing electronic health record functions to effectively deliver information to clinicians. These modifications could include automatic messages or emails to alert providers of critical results. Hoyt states CIPO has the potential to reduce medication errors through a variety of mechanisms. Because the process is electronic, users can embed clinical decision support that checks for allergies, contraindications, and other alerts. Koppel et al. List the following advantages of CIPO compared to paper-based systems for patient safety. Overcomes the issues of ineligibility, fewer errors associated with ordering drugs with similar names, more easily integrated with the decision support systems than paper, easily linked to drug interaction warning, more likely to identify prescribing physicians, able to link adverse drug event reporting systems, able to avoid medication errors like trailing zeros, creates data that is available for analysis, can point out treatment and drugs of choice, can reduce under and over prescribing, and prescriptions reach the pharmacy quicker. EHRs are being utilized with the functionality of CDSS and CIPO and are decreasing medical errors when utilized within the health information systems. Alotabi and Federico state there is substantial evidence that implementing electronic medical records reduces medical record errors and improves patient safety. Computerized physician order entry and CDS are probably one of the most beneficial health information technologies for improving patient safety. In addition, ADC systems and PDMS seem to improve patient safety in critical care settings. They continue to say currently there is insufficient evidence to reach a conclusion on patient safety outcomes for the following health information technologies: electronic sign out and handout off tools, smart pumps, barcode medication administration, retained surgical items detectors, patient portals, telemedicine, and electronic incident reporting. It is worth mentioning that there is evidence that the aforementioned technologies seem to improve healthcare processes and non-safety outcomes. Campanella et al. Found in their study that HIT and EHR created a higher guideline adherence by 133%, lowered medication errors by 46%, and reduced adverse drug effects by 66%. At the conclusion of their study, they stated EHR system, when properly implemented, can improve quality of health care, increasing time efficiency and guideline adherence, and reducing medication errors and ADEs. Strategies for EHR implementation should be therefore recommended and promoted. More than 20 years ago, it was identified that medical errors were attributing to patient deaths in alarming numbers. Flowers and Riley reported, which revealed that the Institute of Medicine recently reported that preventable medical errors cause thousands of unnecessary deaths and serious injuries every year. Widespread media attention to the problem has captured the interest of state and federal policymakers, prompting them to seek solution. The IOM proposed several error prevention and reduction strategies. Among them are implementation of state-based mandatory reporting and public disclosure of reporting information. As states consider whether to adopt the recommendations, information about the policy objectives served by mandatory reporting, the legal environment in which the reporting systems operate, the pros and cons of protecting data, and the ways to protect data may prove useful. The purpose of this report is to inform the debate on these and other mandatory systems issues as policymakers consider how to protect patient safety and improve the quality of healthcare. Although the importance of preventing medical errors in all healthcare settings is recognized, the focus of this report is on mandatory reporting of all medical errors in a hospital setting. 9 years after this, President Obama signed into law the American Recovery and Reinvestment Act, which included the HITECH Act and created programs under Medicare/Medicaid to issue incentive payments for meaningful use of certified EHR technology. The U.S. Department of HHS was given the responsibility for creating the standards for implementation and certification criteria for EHR technology. It was 6 years until in stage 3 in 2015, data was to be used to determine the outcome to generate improvements in quality, safety, and efficiency. Most recently, as 10 December 2020, Senator Van Hollen, Democrat, Maryland, introduced the following bill, which you can see here on the slide. This bill is intended not only to make the changes as shown by the bullets, but also to give a report to Congress that no later than July 31st of every odd number year, beginning with the first such year after the date of submission of the first strategic federal plan to improve diagnosis under paragraph 1, the council shall prepare, submit to the Secretary and Congress, and make publicly available an updated strategic federal plan to improve diagnosis that includes such updates as the council determines to be appropriate, information on the overall progress of the federal government in reducing barriers to research on and supporting projects to improve diagnosis in healthcare, and legislative and administrative policy recommendations, including addressing any needs for greater legislative authority to meet the 2 objectives listed in the subsection B. There would be no doubt that healthcare information technology is an important tool for improving healthcare quality and safety. But healthcare organizations need to be selected in which technology to invest in, as literature shows that some technologies have limited evidence in improving patient safety outcomes. Legislation has done little to enhance patient safety and quality of care. As 20 years ago, the issue was identified and medical errors still persist. What became apparent through my research is that one standard for EHR, CPO, and CDS and clinical guidelines is needed, and mandatory reporting and tracking by the CDC to identify common errors to be addressed. The following slides contain the references in this presentation. First, I would like to offer the following thoughts on how this applies to Christians working in the healthcare field. If we confess our sins, he is faithful and just and will forgive us our sins and cleanse us from all unrighteousness. If we say that we have not sinned, we make him a liar and his word is not in us. 1 John chapter 1, verses 9 through 10. Errors will be made no matter what system is put in place. However, unless there is honesty and accuracy in the reporting of medical errors, they will continue to grow at a larger rate. Christians in the healthcare administration field should encourage and display honesty in their profession. This will honor God, reinforce ethical medical care, and enhance patient safety and quality of care. Thank you for your time and attention. I hope that you have found this information insightful. I'd like to tell you God bless. This ends my presentation.